He currently practices as a hematology oncology hospitalist in the Sylvester Comprehensive Cancer Center. In addition to his clinical work, he is on the clinical ethics, professional education, and blood utilization review committees at JFK. Please join me in welcoming him as he presents on the Emperor of all Maladies.
Thank you very much. It's always a pleasure to be here among you. Good afternoon, everybody. I run the inpatient unit at Sylvester with a hematologist, and I work daily with cancer patients who experience immense stress and anxiety and oftentimes desperation. Patients experience the diagnosis of cancer as one of the most traumatic and revolutionary events that has ever happened to them. And independent of prognosis, this diagnosis brings a change in person's self-image and their role in family and work. A person who's just been diagnosed with pancreatic cancer has the same prognosis of a patient who has severe aortic stenosis when they experience the first symptom of heart failure. Yet, patient with cancer, they perceive this diagnosis as it alters their self-image, and they feel that their body is failing. By contrast, patients with pancreatic cancer, they feel they still maintain their intact self-image, and they only perceive that they have a functioning body, but it's only a dysfunctioning organ. And it's quite an interesting and exciting time in oncology and cancer treatment now because of the advent of immunotherapy and a lot of technological advancements. I read this book not a long time ago, and I thought I would like to share with you some of the really interesting things. I will review some of the historical events and development in cancer research since the time we heard of cancer. The first recorded cancer was the oldest description of cancer was discovered in Egypt and dates back to this 1500 BC. And this papyrus is called the Edwin Smith Papyrus. That was written by Imhotep, is an Egyptian physician at that time. It was discovered in the year 1862 and was translated in the year 1930. It describes 8 cases of breast tumors, and they were removed by cauterization. And under the treatment, there was just only one sentence says, no treatment. Over a millennium passes until once more we hear of cancer. Inspired by the physical shape of tumor, Hippocrates coined the term karkinos, the Greek word for crab. And there are different opinions of where that came from. One of them is that the hard and matte surface of a tumor was reminiscent of a tough carapace of a crab's body. Another opinion is that it looks like a mass engorged with blood vessels surrounding the tumor. And it kind of looks like that. And also the word onkos is a Greek word for mass or burden, which was also the origin for the word oncology that we use right now. The concept of 4 humors originated with Hippocrates. The blood, black bile, yellow bile, and white bile. Galen, who was a Greek philosopher and surgeon, thought that an imbalance of the black bile was the origin of cancer. The appearance of tumors were merely a symptom of systemic dysfunction, and black bile was everywhere. And his teaching advised that surgical treatment was ineffective. Is a representation of melancholia with black bile. And this theory of cancer was so metaphorically seductive that it clung on tenaciously in the minds of physicians at that time. 1,400 years later, Vesalius, a Belgian physician, created one of the most influential books on human anatomy. He used specimens smuggled from graveyards and dissected hundreds of bodies to better understand human anatomy. But a big troubling discovery he made was the lack of black bile. No matter how diligently he pours through the body, he could not find Gallen's black bile. And by the 17th century, some surgeons were attempting to remove tumors surgically in defiance of his teachings. And this is a black and white photograph representing also an early surgical procedure. The invention of anesthesia and antisepsis, these were twin technological breakthroughs that released surgery from its constraining medieval evolution. William Morton discovered anesthesia in the year 1846, and Joseph Lister discovered antisepsis in the year 1865. Rudolf Virchow is a German biologist and pathologist who's known as the father of pathology. His studies of the two modes of cellular behavior, hyperplasia and hypertrophy, eventually led to the classic disease of pathological hyperplasia, which is the cancer. His new theory had slowly emerged after his death. In the year 1832, Thomas Hodgkin, who is an English anatomist, he discovered what would later be known as Hodgkin's lymphoma, using his own system that organized pathological anatomy by organ rather than disease. Paul Ehrlich, the famous German chemist and physician who was the first to coin the term chemotherapy, and he defined it then as the use of chemicals to treat diseases. He worked with cloth dyes and discovered their application in staining tissues. What if some chemical could discriminate bacterial cells from animal cells and kill the former without touching the latter? He also was interested in drugs to treat cancer, including dyes that basically initially was alkylating, primitive alkylating agents. William Halsted was born in the year 1852. He pursued medicine to avoid becoming a merchant like his father. He was fascinated by anatomy, and he worked as a surgical intern in New York. Then he traveled to Europe to study more surgical techniques. Then he returned back to the United States and was recruited to lead the surgical department at Johns Hopkins. He's known for the very morbid and disfiguring radical mastectomy. And from the year 1895 to around the mid-1970s, about 90% of women who had breast cancer underwent Halsted radical mastectomy. The radical mastectomy represents a milestone in the treatment of breast cancer. This is one of the pictures, Halsted in the operating room. In the year 1895, the X-ray is discovered by Röntgen, and he received the first Nobel Prize in physics. In 1896, the ability of X-rays to selectively kill rapidly dividing cells inspired a 21-year-old Chicago medical student, Emil Grubb, of the notion of using X-rays to treat cancer. And this is a picture, the first X-ray actually was taken. This is the left hand of Röntgen's wife, Maria. In the year 1902, radium chloride was discovered by Mary and Pierre Curie. And these discoveries on its implication for cancer weren't far behind. This is a picture of children receiving early radiation therapy. Initially, relatively, we began with using low voltage diagnostic machines, and it was a major breakthrough when it was discovered that daily doses of radiation over several weeks greatly improved the patient's chance of cure. And this is also a picture of a small child receiving radiation therapy. So I'm going kind of as a historical, basically how we changed through history, how the discoveries and inventions. This is the first oncovirus was discovered in chicken by the pathologist from Baltimore, and he received Nobel Prize, and he developed the somatic mutation hypothesis of cancer. So cancer medicine prior to that in the early 20th century was stuck in a rut because of the depth of medical mysteries and that surrounded it. In May of 1937, Fortune magazine published an article titled "Cancer, the Great Darkness," in the endeavor to arouse the layman to fight the disease. And it was darkness in both medical impact of the disease and complete lack of political and social transparency. Research was underfunded and it was not given the public attention it deserved. In August 1937, the National Cancer Institute Act was signed by President Roosevelt, and $700,000 for each fiscal year were authorized to fund research cancer. And this is an image of first meeting of National Cancer Institute. In the start of basically 1940s, it marked the 3 decades of intense growth in the field of cancer treatment. Mary Lasker, who was a child to a banker, had very successful business. She and her husband, Albert, they created the Lasker Foundation for promotion of medical science and research. And she was among the first to use her power as wealthy socialite to promote cancer. 1945 was the birth of the American Cancer Society. Lasker, Farber, and the American Cancer Society partnered to help raise a profile of cancer research in the public sphere. Sidney Farber, who is known as the father of the modern era of chemotherapy, he recognized that the folic acid stimulated leukemic cell growth, and so he hypothesized that folic acid antagonists would inhibit or arrest the proliferation of cancer cells. So he developed aminopterin, which is methotrexate, and it's very widely used right now and still is used to treat several cancers, including leukemia. And that was the first treatment that provided positive results in leukemic patients. And Robert Sandler was the first patient to receive methotrexate for acute leukemia. Then the Jimmy Fund in 1948 was started. Jimmy was a patient of Dr. Farber, and the first campaign raised more than $200,000 in donations. In the year 1952, Papanicolaou Trial was the largest clinical trial in secondary prevention in the history of cancer. And it changed the spectrum of cervical cancer from predominantly incurable to predominantly curable. In 1957, the U.S. Surgeon General issues a joint report of study group on smoking and health, and this marked the first time in the U.S. that Public Health Service takes a position on smoking and health. In 1961, the American Cancer Society and the American Heart Association sent a joint letter to President Kennedy asking him to appoint National Commission to investigate the link between smoking and health. Just gonna skip. In 1961, this was the first time combination chemotherapy was used: vincristine, aminopterin, mercaptopurine, and prednisone. And this is Madagascar periwinkle vincristine comes from. In 1961, Epstein-Barr was first just discovered to be confirmed in humans and is commonly associated with Burkitt lymphoma and Hodgkin's lymphoma. This discovery basically launched a huge research effort in linking cancer to curable condition. In 1962, the first medical linear accelerator in the Western Hemisphere was invented by Henry Kaplan. And America's war on cancer began in 1971 with President Nixon signing National Cancer Act. And basically this act provided unprecedented level of funding for a National Cancer Institute, over $400 million in 1972 and $600 million by the year 1974. And then later in the years 1960s and 1970s, the routine screening contributed to 40% reduction in colorectal cancer. And this is Hounsfield prototype scanner. This was the first scanner that was invented, and the first clinical CT scan on a patient took place in October in 1971 in London. And the first clinical scan in the USA was in Mayo Clinic in 1973. In Hounsfield and Cormac, they received, they shared a Nobel Prize in 1979. The first confirmed oncogene was discovered in 1970 by Michael Bishop and Harold Barmas at UCSF. And then 1976 launched a mammographic screening trial and showed that screening may lead to 20% reduction in death in women over 55. In 1977, a pivotal trial combining cisplatin, vinblastine, and bleomycin showed that it can cure 70% of patients with advanced testicular cancer. Today, overall cure rate of testicular cancer in all stages is a remarkable 95%. Bernard Fisher is recognized today for his groundbreaking research in breast cancer, which ultimately ended the standard practice of performing Halsted radical mastectomy. Barry Marshall and Robin Warren demonstrated that H. pylori was the cause of most peptic ulcers, and their research established a link between bacterial infections and cancer. The adjuvant trastuzumab trial was a milestone in the treatment of HER2-positive breast cancer. And this is Dennis Salmon, who invented that. The Gleevec trial, one of the most successful trials in the history of cancer. Imatinib, it's a drug that was approved in 2001 for CML, ranks perhaps as the most effective cancer treatment we have developed to date. The Human Genome Project was one of the great features of exploration in history and an inward voyage of discovery rather than an outward exploration of the planet. It's an international research effort to sequence and map all of the genes, and together known as the genome. For cancer researchers, the completion of this map of human genetics was crucial in their exploration of genomic path of cancer. And this led to an ambitious new initiative, which is the Cancer Genome Atlas. It aims to identify all genetic abnormalities seen in 5 major types of cancer. Based on a deeper understanding of disease at the genomic level, we will see a whole new generation of targeted interventions, many of which will be drugs that are much more effective and cause much fewer side effects than the drugs that are available today. It's a huge database, and it's publicly available and has been used widely by a research community. The data has contributed to more than 1,000 studies of cancer by independent researchers. And this is just a list of some of the targeted therapy that have been approved in the last few years. And that was also an effort of that project. So the remaining challenges, basically, in the United States, approximately about 500,000 people still die from cancer every year. And worldwide, the number of new cancer cases will more than double by the year 2030. And many forms of cancers are so hard to detect until they're advanced, and when treatment is generally less effective. And one of the most very important thing is that too many Americans lack the adequate insurance coverage for cancer care as the cost continues to rise. I was hoping to talk, because this is really the exciting time, talk about the current advance in the last 10 years, immunotherapy and CAR T-cell. But for the interest of time, it was just more of a kind of like a journey of since we heard about cancer till this date. And hopefully on a future time, we can kind of talk more details about that. Some references here. Thank you for your attention. This is some of the team I work at Sylvester. Thank you.
Thank you, Wassim, for that review. Does anybody have any questions?
Short question.
Yeah.
I'm really fascinated about this cancer screening. I don't know much about this. Could you do one or two tests? Because I think it's just one of the amazing things. So you can some PCR test, and you can even treat the cancer before you even see it. So the PCR test treats for that cancer, for example, and then see the marker disappear. How close are we to this?
Yeah, it's a great question, and it's
Not close.
it's
No, we're not
so
close. All right, thank you very
My
much.
pleasure.
Time will go to research.
Thank you.
Pull up the other. Do you know where you're? I'll take care of it. Okay. All right. Thank you. Our next speaker is Dr. Efren Manjarrez. He is an associate professor of clinical medicine and former chief of the division of hospital medicine at the University of Miami Miller School of Medicine. He graduated from UC San Diego School of Medicine and then completed his MedPeds residency here at UMJMH. Among his career highlights, he co-founded the first MedPeds hospitalist group in the U.S. He founded hospital medicine here at UM in November 2000. He completed a faculty development training at UNC Chapel Hill, as well as advanced training in quality improvement and at Intermountain Healthcare in Salt Lake City. He was part of the team that won the Innovation of the Year at the meeting for improving glycemic control in hospitalized patients in over 100 hospitals. He also edited the nephrology, urology, and hemo sections of SPARC, the Society of Hospital Medicine's MKSAT-like product. His publications are patient safety quality improvement, perioperative medicine handoffs of hospitalized patients, and cultural competency. Please join me in welcoming Dr. Manjarrez as he gives an update in perioperative medicine. Thank you.
Wow, it's great to be here. This is my 5th time giving internal medicine grand rounds in my career here, over 18 years, and I enjoy every time. And each time, Dr. Matterson's been sitting in the front row, and Dr. Gardner's been there, and my program director, Dr. Gelbard's been there, supporting me as always. So let's talk perioperative medicine, all right? This is actually my favorite area of clinical medicine. So, without further ado, no disclosures. However, if anybody wants to give me gifts, anything I can declare to Dr. Weiss and the university, knock yourselves out. All right, 3 things we're going to go over today. Preoperative risk assessment, perioperative myocardial injury, and VTE prophylaxis. That's all I got in 30 minutes. And so, let's start off with a case. So you're asked to pre-op a 71-year-old lady for surgical management of a colovesical fistula as a complication of diverticulitis. Notable history, she was revascularized 10 years ago for a non-STEMI. She's got hypertension, diabetes. She's on insulin, an ACE inhibitor, a statin, and baby aspirin, not on a beta blocker. She denies chest pain or shortness of breath, but is a bit of a couch potato. Her exam is normal, but she's a little obese, and because the chairman's a thyroidologist, I put in she had a goiter. Labs show a creatinine of 150. I'm sorry, glucose of 150, a creatinine of 2.1. I know. And I know. So, and an EKG showing no acute changes, nothing specific. What is your next step? I'll take one volunteer. Per your subjective assessment, residence, she could probably do 4 meds and go to the OR. Fill out the Duke Activity Status Index. Get a pro-BNP. Just stress her like the guidelines say and be over it. So what do you think? One person? So the MET study was actually created to sort of look at this issue by Duminda Vyasundara, who's a big research anesthesiologist in Toronto. Had the great pleasure to have a conference call with him about a month ago with our Society of Hospital Medicine perioperative group to go over the study. And the needs assessment is that functional capacity is an important component of preoperative risk assessment. It's in our own ACC guidelines. The cardiologists know this backwards and forwards. It's also in the European guidelines. And so the big question is always, according to functional capacity, can they do 4 METs, right? That's can they walk 4 blocks at a good pace, or can they climb 2 flights of stairs? Sounds familiar for the MOD residents, right? Sure. So, however, the background is that physicians' subjective assessment of functional capacity doesn't have good validation with other areas that are validated assessments of functional capacity. And furthermore, there's no correlation with hard clinical outcomes perioperatively. So the research question was, can subjective physician assessment of functional capacity, how does that correlate with 3 other measures? Cardiopulmonary exercise testing, bike riding and doing spirometry in a monitored setting, filling out this survey called the Duke Activity Status Index, getting a pro-BNP, and comparing this to perioperative and long-term death as well as other cardiac outcomes and non-cardiac outcomes, okay? So big study, 25 hospitals across the world, Canada, the UK, and Oceania. There were 1,400 patients who were 40 or older that were coming in for elective non-cardiac surgery under general anesthesia at least 1 night in the hospital setting with at least 1 risk factor for coronary disease. And these are the primary outcomes. 1 month death or MI, 1 year death, and then there's some other outcomes I'm going to share with you as well. All patients who underwent surgery and completed the cardiopulmonary exercise testing were included in the primary analysis in an intention to treat fashion. This is the Duke Activity Status Index. Basically, you add up all the points of all the things that the patient can do. Pretty easy to do in the office or on MOD rotation. And you added up all the points. The maximum points are something like 56 points. Here's a little bit of the demographics. I just wanted to show you just a little bit about what they had. Very few patients in this study actually had heart failure or coronary disease. Very few patients had significant kidney disease of stage 3 or above. When you look at their revised cardiac risk index, the revised cardiac risk index, you will remember, is major surgery, cerebrovascular disease, coronary disease, heart failure, a creatinine of over 2, or the use of insulin. 6 factors. 90% of these patients had either 0 or 1 of those factors. And there were very few patients on beta blockers going in the study, and there were relatively few high-risk patients undergoing vascular, thoracic, or intra- or retroperitoneal surgery. With respect to the cardiopulmonary exercise testing, 11% were not able to complete this. And the biggest reason was they weren't able to pedal. I thought when you learn to ride a bike, you don't forget that stuff. The adverse events, there were 8% of patients that had adverse events. It was largely elevated blood pressure. So some baseline results. I'd like to focus you on that top line, the red, poor functional capacity, less than 4 meds by subjective assessment. Only 8% of patients were deemed a high risk in that respect. When you look at their peak oxygen consumption, the mean was 19.2. Now, when you're thinking, well, gee, Dr. Manjarrez, how does that correlate with your metabolic equivalents? About 14 mLs per kilo per minute is about 4 meds. The Duke index score, you can see the means there were relatively high, and the pro-BNP were within normal limits for the cohorts. If you look at the peak oxygen consumption, though, versus the moderate risk to high risk, the moderate risk to good functional patients on the right, we were pretty good. Physicians were actually pretty good at saying, you know, that patient is good doing exercise. Their functional capacity is good. But if you look to the right, all those patients that didn't meet 4 METs, the physicians only picked up less than 20% of those. And yet a lot of these patients were pushing on to surgery. So we're correctly picking up the patients that do well, but unfortunately we're doing a poor job when we interview patients of picking up those patients who are at risk. Let me focus you on the lower left and the lower right on this picture. And basically the peak oxygen consumption, which higher is better, it correlates with a more positive Duke index. The more things you can do on Duke index, the more oxygen consumption, and that's better. However, those patients with a high pro-BNP, of course, correlated negatively with oxygen consumption, and that was bad. So here were the outcomes. If you look at 30-day death or myocardial infarction, the one that actually correlated was the Duke index. The higher your Duke index, it was protective for that primary outcome. When you look at 30-day death or just myocardial injury, both the Duke index, a good score on the Duke index, or a high pro-BNP, a good score on Duke index is protective, but the high pro-BNP showed elevated risk. When you look at 1-year death, the pre-op pro-BNP that was elevated had a higher risk of 1-year mortality. And then when you look at peak oxygen consumption, poor performance on peak oxygen consumption actually resulted in these other outcomes I'm going to share with you next. So the results. Believe it or not, subjective assessment of functional capacity did not have an association with the main study outcomes, which was cardiovascular death at 30 days or at 1 year. But a poor performance on the cardiopulmonary exercise testing actually resulted in all these other negative, hard clinical outcomes, some of which resulted in death, and obviously they all prolonged the length of stay. So what were the limitations of this particular paper? Well, 90% of these patients had a low revised cardiac risk index. They were relatively low risk, but yet we did see these complications. There were relatively few higher risk surgeries, but yet we did see these complications. And there was a relatively low usage of beta blockers and antiplatelet agents in this study. So the conclusions were that subjective assessment of functional capacity should not be used for preoperative risk assessment. It does not accurately identify patients who have poor fitness, nor those at risk for postoperative complications, even though they weren't cardiac. A poor Duke index score predicted 30-day risk of death or MI. A high pro-BNP predicted short-term and long-term death. So again, we should consider more objective measures of functional capacity like the Duke index and the pro-BNP for cardiac stuff. But again, the exercise performance tests for these other measures that realistically, they weren't even actually the primary outcomes that were found. Okay? So the case actually continues. The patient returns from the operating room in sinus tachycardia at 103. Blood pressure is stable. She denies chest pain, but she's still lethargic from anesthesia. As you review the anesthesia record, you see that she received 1 unit of Pac-Reds for intraoperative bleeding. You bite the bullet and you order troponins and an EKG. You're thinking, what happened in that OR? The EKG showed no acute changes, but the troponin T comes back at 0.07. We see this all the time, right, MOD residents? Absolutely. So what do you think is going on? Her 30-day mortality rises. She had an MI despite the lack of chest pain. This is all non-cardiac BS. You should anticoagulate with aspirin and dabigatran. Thoughts? You'd go with A. I'd agree with you. Aspirin and statin and go to the cath lab. So that's what the MANAGE trial looked at. This is P.J. Devereaux, who's a big cardiac researcher in, I believe, McMaster in Canada. So the MANAGE trial was evaluating dabigatran in patients with myocardial injury after non-cardiac surgery. And those of the residents that have heard my pre-op lecture know that this is MINS. This is MINS. And this is a term that just came about 6 years ago. So the background to this is that myocardial injury after non-cardiac surgery actually increases the risk of perioperative cardiovascular events and death. And at present, we don't have a known risk reduction strategy for this. You can't take them to the cath lab and you can't do, thrombolytics on them because they're going to bleed at their surgical site, right? Now, what we do know is that dabigatran is known to reduce perioperative VTE. It's actually in the ACCP guidelines. And so the question that the investigators had was, can dabigatran's benefits be extrapolated to treating MINS? Does dabigatran decrease perioperative major adverse cardiac events, which we call MACE, after non-cardiac surgery in patients with MINS? So this was a randomized clinical trial, 84 hospitals, 19 countries, almost 1,800 patients who underwent non-cardiac surgery and who on the postoperative days 1 and 2, they either had some EKG changes, they had a positive troponin, they had positive cardiac imaging that showed the possibility of myocardial damage. But what they didn't have explaining all this was a chronic elevated troponin because of kidney disease. They weren't in rapid AFib, and they weren't septic. So again, they were trying to limit this to what's true cardiac cause of an elevated troponin. The mean follow-up in this study was 16 months, and the primary outcomes were vascular mortality, major adverse cardiac events, which in the literature is defined as fatal or non-fatal MI, unstable angina, or heart failure. And then they had these other outcomes, which are non-traditional outcomes. And the primary safety outcome, of course, is bleeding. So I'd like to take you to the VISION study, which was published a few years ago. The VISION study, if you look at the bottom right, this troponin T is actually within normal limits. But if you look to the y-axis, you see the cumulative hazard at 30 days of death is not 0. They have normal troponin T, and they actually have a mortality of about 3 or 4%. Let that sink in for just a minute. Sorry. If you look from 0.03 to 0.29, those are patients that are sluggishly positive. They actually had a mortality rate at 30 days of a little bit less than 10%. And if you went above 0.30, their mortality was actually a bit higher, closer to 20%. Mind you, these were not patients that had a classical perioperative MI. Now, I know that the font is a little small here, so I'm going to walk you through this. The MINS diagnosis. The MINS diagnosis, 80% of these patients had an isolated elevated in troponin, and only 20% of these patients actually had a classical MI. Okay? And these patients were diagnosed within the first 24 hours after surgery. If you look at the medications, almost 60% of these patients were actually taking chronically aspirin or a P2Y12 inhibitor or both. Beta blockers, they were taking almost 40%, and statins about 50%. when you look at the primary outcome was a composite of all these things, right? It was major adverse events, but then they added stuff: peripheral arterial thrombosis, amputation, symptomatic VTE. And you can see that there was a benefit versus placebo for dabigatran. But the problem is that halfway through their study, the investigators lost funding, and they were supposed to have 3,200 patients, but they ended up recruiting only 1,700, and they ended up adding these outcomes, amputation and symptomatic VTE, which we actually know dabigatran helps, right? We know that helps. So again, this was one of the flaws of this particular study, despite the fact that there was a positive outcome. But when you did the subgroup analysis, there was actually a reduction in ischemic stroke. Everything else was unchanged. So again, a lot of these outcomes here are not typical for major adverse cardiac events, and it sort of skews the data. If you look at the Kaplan-Meier survival curves, you can see that the patients with placebo had a higher event rate. No question about it after 24 months. When you look at the safety outcome, it's bleeding. And the bleeding, there was actually no differences in the composite of all these different types of bleeds. Typically, when they do anticoagulant studies, the bleeding outcomes are CNS bleed, GI bleed, major organ bleed, retroperitoneal, or they lose 2 units of packed reds. In this one, they actually changed the definition to 4 units of packed reds. But regardless, there was no definition, no change. When you did further subgroup analysis, the only patients that actually had a benefit to this were those patients that were randomized into the study within 5 days of MINS. Those patients that actually met criteria for acute MI were the ones that benefited, not the ones that had the isolated troponin. And there were some that had peripheral arterial disease as well. And the business about the MI patients benefiting brings up a whole nother question that I hope to engage my cardiology colleagues in, which is there a role for DOACs in the treatment of acute MI? And is there a different balance that should be used with DOACs and antiplatelet agents? And I haven't read that literature, but I'll engage Dr. Cohen shortly. So this was actually the first clinical trial specifically aimed at improving outcomes for patients with MINS. We'd been dealing with this for the last 4 years, and previous to this, the only thing that we had seen is perioperative use of aspirin and statins, and then call your cardiologist and hope for the best. Now again, caution in interpreting these data, because the definitions and endpoints of MACE were a little bit different than what we typically use. Venous thromboembolic events, we know are benefited by DOACs. We know because they're already in the guidelines for treatment. And dabigatran only helped the patient with acute MI, not MINS. And dabigatran did reduce non-hemorrhagic stroke, which I don't really know what to make of that. And as I mentioned earlier, the jury is still out on the appropriate mix of antiplatelet agents and anticoagulants like DOACs for treating this patient population. Is there a role? To which I'd be curious to know what my cardiology colleagues say. All right, last case. So this is a 73-year-old lady that you're discharging after a left total hip arthroplasty. And you're thinking over your options for extended DVT prophylaxis. And she's already received 5 days of rivaroxaban while she was hospitalized. All of the following are viable options except complete up to postoperative day 35 of enoxaparin, complete up to postoperative day 30 of aspirin, complete up to postoperative day 30 of rivaroxaban, complete up to postoperative day 14 of unfractionated heparin. They're all acceptable. Any thoughts? Good. That's why I can teach you this paper. This is EBCAT 2. Aspirin or rivaroxaban for VTE prophylaxis after hip or knee arthroplasty. Published almost a year ago in the New England Journal. So the background and the needs assessment to the study is that clinical trials and meta-analyses show that aspirin's effective for the prevention of VTE perioperatively in orthopedic patients, believe it or not. And the orthopedic surgeons that we work with here actually use aspirin, right? Dr. Rubenfeld's shaking his head, yes they do. But there's been no randomized clinical trial comparing aspirin with the DOACs. EBCAT 1 actually looked at aspirin versus Lovenox. And so we actually know that it works. But what about with the DOACs, since the DOACs are gaining a lot of momentum? So the research question. What's the effectiveness of extended prophylaxis of aspirin versus rivaroxaban in preventing VTE events, PE and DVTs, in patients who had hip arthroplasty or knee arthroplasty after a short course of rivaroxaban. Mind you, this isn't hip fracture, it's elective hip arthroplasty. Hip fracture patients have a much higher risk, and they weren't studied in this particular paper. Double-blind randomized clinical trial of 3,400 patients. 1,800 had hip arthroplasty and 1,600 had knees. So the protocol was pretty simple. Everybody got 10 milligrams orally of rivaroxaban for the first 5 days. And then if you had a knee arthroplasty, the arm was you continued up to 14 days with rivaroxaban, or you switched over to baby aspirin for 14 days. With respect to the hip arthroplasty patients, it was similar, but instead of going up to 14 days, they went to 30 days in the two arms of the study. So the effectiveness and safety outcomes. Venous thromboembolism, whether you split it up or lump them, if you're a lumper or a splitter, there was no difference. There was no difference between rivaroxaban and aspirin. When you look at major bleeding and any bleeding, there was no difference. No difference between the groups. Now, I know that those people who do a lot of perioperative medicine, and I know that the MOD residents are saying, but Dr. Manjarrez, the patients who have hip arthroplasty, they have a higher risk of DVT and PE than do those knee patients, right? I know that's what you were thinking. Reggie Pereira is shaking his head. That's right, Dr. Manjarrez. So they split them. They split them into total hip and total knee. And again, whether you lumped them or you split them and you looked at the bleed, there was no significant difference between the groups. They even looked at patients who were on chronic aspirin prophylaxis for other indications like stroke or peripheral vascular disease or coronary disease. And again, there was no difference in VTE or safety events. So the conclusions for EPCAT-2, and again, I'd like to caution, this is not a rivaroxaban versus aspirin study, okay? It's after a short course of rivaroxaban, then you give aspirin or rivaroxaban to complete the course. Among patients who had 5 days of rivaroxaban prophylaxis for hip or knee arthroplasty, electively, extended prophylaxis with aspirin was no significant difference, whether for efficacy outcome of clots or safety outcomes for bleeding. So, I finished, and we actually are done in time. As we look at this, the take-home points are physician's subjective assessment of patient's functional capacity prior to non-cardiac surgery is flawed. It's flawed. And now we've got the evidence. We had been going through the dogma of the ACC guidelines ever since I was a resident here as MedPeds. But realistically, we never had great data on this. And it probably must have been expert opinion or consensus. So consider administering a Duke Activity Status Index or ordering a ProBNP for a more closer to objective measurement. As we know, a ProBNP realistically measures myocardial stretch, right? Myocardial stretch. At present, patients who exhibit perioperative myocardial injury, MINS, with or without a diagnosis of MI, are at an elevated risk of mortality in the short term and in the long term. So the jury's still out on the best risk reduction strategy. Obviously, we have to call our cardiologists. Do not exhibit benign neglect, but this was the first study that specifically targeted that, and it's opening up a whole nother paradigm of treatment for these patients who are spilling troponins and having a bad outcome. Dabigatran may actually help those patients who meet the criteria of acute MI, to which our cardiologists will guide us in terms of, is there data for DOACs, and is there a mix? Is there something coming forward with the mix between DOACs and antiplatelet agents moving forward in the surgical or non-surgical setting? And aspirin, yes, aspirin is actually an option for postoperative VTE prophylaxis after elective arthroplasty, after initial 5 days of rivaroxaban. Now, in this particular study, however, they excluded high-risk patients, which were patients who had lower extremity or hip fracture or metastatic cancer, because those patients are much more hypercoagulable. So again, elective hip or knee arthroplasty. And so in summary, we've covered preoperative risk assessment, we've covered myocardial injury, and we've covered DVT prophylaxis. And as always, it's an honor to be here to talk to you guys. Thank you so much. I'm happy to take your questions.
Efren, that was a great update. Thank you very much. Does anyone have any questions? Yes?
So, based on the differences between aspirin and the rivaroxaban that was done in that CAP trial,
Yeah.
what they did was 5 days of rivaroxaban after the patient gets an elective hip only.
Right.
But in the most recent times, an elective hip only, most of them can go home the next day.
Right.
So, but they haven't seen any of that, like people getting 5 days of rivaroxaban. So, do they go home? Like, can we start them on aspirin the next day and then just say, okay, the data is probably
So,
the same?
thank you, Sid. Dr. Tamanini is asking, but these patients go home after 24 to 48 hours. Many of them end up going to rehab. So again, it provides a more cost-effective way. As we know, the DOACs are not cheap, so it does provide an opportunity to use a different agent. And again, the transition of care is obviously an issue that in great research circumstances were controlled, but in the real world, it's something that we have to live with as hospitalists and others that care for these patients. Good question.
Anna?
During study, the bigger count person they asked to be extended for prophylaxis, the event rate was very low. So, are you aware of any prospective or retrospective cohort studies that look at a difference and have enough power at a population level?
So the question was, is there a good study looking long-term at these patients with dabigatran or aspirin or any other? The truth is that the guidelines prefer you, and the guidelines were written in 2012, they actually prefer you to use Lovenox. But since that time, there's a lot more data coming out with the DOACs. And again, aspirin. So the best data back then was with Lovenox, long-term.
Joe?
Do you use the, in terms of the perioperative scoring system?
Yes.
Are you using the statistical?
I don't use the Dukes. So, the ACC algorithm says, first of all, is the patient having emergency surgery? If they are, like a trauma, they go to the OR. If they're having an acute MI, you treat them according to guideline directed. Then you risk stratify according to the revised cardiac risk index, right? And then if the revised cardiac risk index is high, they can go to the operating room if their functional capacity is good. So what I'm telling you now is we're doing a flaw, you see those patients, you're like, I think they can do 4 meds. And what I'm telling you here is that according to their data with not high-risk patients, those patients that we're sending to the OR that we as hospitalists discharge and we don't really follow them up, but you as general internists do, they're having some problems with that. And so is the guideline from the ACC going to be changed? I think we need a little bit more data. Is there a mix of treatments, of testing, diagnostic testing, and biomarkers? Again, inquiring minds want to know. What I'm simply raising to you is that the way that we're thinking about the preoperative risk assessment, the dogma all these years, the functional capacity, we're flawed. And so we have to think about other things. I think the Duke Index would be great to do. I've ordered pre-op BNPs in patients. I've ordered that multiple times when I've seen patients, particularly when I used to do UPAC. I would do that all the time with somebody that I thought was a little concerning for that had heart failure or shortness of breath for any cause.
Okay, well, thank you very much, both speakers. Next week we will not have grand rounds. I wish you all a happy Thanksgiving and be safe, and we'll resume in 2 weeks.